So I thought before kind of delving into the lecture that I'd actually share a little bit about myself as well as my organization. So coming into undergraduate, I had some very particular interests. Law, civil rights, and language access were some of the things that I felt very passionate about. I'm mixed heritage, I'm Mexican and white, and so I always felt like I was sort of walking these borderlines, if you will, trying to understand the benefits of being a mixed person. What were some of the challenges that my Latino compadres were dealing with, and at the same time having really difficult conversations with other parts of my family about race relations. So when I got in to become an undergraduate, really felt like this was going to be a place of critical thinking, of analysis. I wanted to really delve deep to understand not just what my future career path would be, but also to get a better understanding of where we were from, like where we came from, what was the historical background to all of this. And so throughout my college career, I was able to identify these little nuggets of opportunities to make those connections with law and civil rights and language access. And so through my career, I looked at things like work and migration, for example, did some research around that, looked at motherhood and immigration, looked at community enclaves and resilience, and then spent a good chunk of time really understanding the impact of immigrants' rights and immigrant law and policy. So at the same time that I was an undergraduate, there was a lot of political activism that was taking place. So not to date myself, but this was in the early 90s. And during that time, California as a whole, as a state, was going through a lot of turmoil. The communities of color were becoming a majority in California, and and then we also were going through an economic crisis. And so what this then related to in California was some very politically divisive laws and policies that were being proposed. And so that in itself, that divisive law and policy, the fact that this was creating environments in which people either thrived or that they didn't thrive and that they were scapegoated, really fueled and sort of intersected to create this career that I now have. Both on a personal level, it was very rewarding, but on a professional level, finding that place to be able to make those changes was just really phenomenal. And so we find ourselves sort of there again, right? As a nation, I think we're also looking at this rhetoric and some policies that are potentially divisive. And so again, sort of falling back on that historical perspective of how did we get here and what can we do to move forward. So that was kind of me. That's me in a quick bite. And then at the same time that this was all taking place, there were 4 ethnic leaders who were coming together to create a space for communities of color to come together. So again, going back to the early 90s, not only was the state having some challenges around relationships and policies, but also within ethnic groups, there were also some challenges. So how many of you are from Los Angeles area? And so I'm sure you've heard of the Rodney King incident, the race riots that happened in the early 90s, right? So that was a place in which communities were sort of fighting against each other, but again, a lot of it was in the name of this broader framework that was, again, creating either opportunities to thrive or creating scapegoats or other challenges within the community. So the leaders of my organization, CPEHN, got together and created a space where communities of color could come together to find the unity, the space in which we all wanted to move issues forward together, because as a separate piece, as separate entities, we weren't getting very far. But coming together and bringing that collective power made a much, much greater difference. So the key focuses of CPEHN's work has been, number one, around improving access to healthcare. And I'll talk a little bit about why that's really important. But the other way that we've been looking at is around data collection and improvement. Because if you don't have the data, and I'm sure you all can appreciate that piece, if you don't have the data, you can't really understand what are the challenges, what is some of the missing information that you may need, but you can't really analyze the trends. And so having that data is really particularly important. And not just having the data, but then analyzing it and reporting it and making it publicly available. We also looked at the healthcare system as a whole and making sure that the healthcare system actually can meet people where they're at. That it's important to have some standardized procedures and processes, but if your physician doesn't speak your language, then you're not going to be able to get very far in terms of being able to manage your own health. And so language and culture are really important in our healthcare system. And the last piece is, and this is a relatively new piece, probably around 10 years old, is looking at the upstream factors of health. And I'll talk about what that means as well. But really creating vibrant communities that are actually helping to promote health rather than creating and furthering health disparities. So our core strategies, and I'll reemphasize this as well as I go through, but the core strategies is around policy and advocacy, and that's really a key factor, looking at those environments and trying to shape the environment and the policies. Also engaging and convening community members. Policy, is not going to be effective if it doesn't actually really incorporate the specific needs of community members. And so we make a very concerted effort to make sure that our community members are front and center in our policy agendas. And then data and research, another key aspect of the work. And so we both put out data and research, as well as encourage our state and local agencies to collect and analyze that data. So the core concepts that I wanted to highlight today are really looking at what are some of the challenges within our healthcare system, and I'm going to talk about that from a health equity perspective. I also want to share the changing demographics of California and sort of why that's important, why it's important to CPEHN's work, and I think important to your work as well. Looking at some definitions and frameworks for health equity. What do we mean when we say health equity? And I know Dr. Sammy is working on some of those too. So, I encourage a lot of discussion around that as well. And then I want to share a couple of policy opportunities that CPEHN has been engaged in, and particularly myself have been engaged in, to try to ensure that health equity is the framework for policies so that nobody gets left behind. So for us, for CPEHN, the role of demographics is really important. And again, it really stems from that idea that in the early 90s, communities of color were becoming the majority of California. So we knew what was on the horizon. We knew that this was going to be an important way that was going to shift how we were going to impact policy in California. Were we going to continue to promote things like Prop 187 and, and scapegoating immigrants or prohibiting immigrants from being able to go to school and being able to receive healthcare services? Or were we going to be inclusive and make sure that people understood that it is okay to seek out healthcare services, that education is important no matter who you are? So those were at that point in time, those were the discussions that we're having. Again, quite similar to what we're talking about today as a nation. So this was really important, and then also looking at where communities of color are in the state of California. So some of our colleagues like to think of this as a fishhook, although I don't know if it really looks like a fishhook, but it's the darker areas that have a majority of communities of color at a county level. And so again, this is where our efforts are pretty much focused throughout the state of California. But again, having that perspective and knowing where communities of color are, what's the dynamic, what's the relationship. And that's important because communities of color often are often reporting, either self-reporting that their health condition is poor or fair compared to whites, but then are also facing health disparities at much higher rates. So again, I'll talk about sort of what causes some of those health disparities, but just important to put in the background that as we look at things like heart disease, diabetes, obesity rates, infant mortality, these are all things that are impacting communities of color at higher rates than other communities. And so again, the data, so a little promotion. We just released a report. It's the third edition of what we call the Landscape of Opportunity, and it actually looks at and examines a lot of different racial and ethnic disparities, and has a lot of these other maps that show sort of where communities of color are and where there's a lack of access to parks, for example. Or where the air quality is particularly horrible. And that's, again, if you start to look at where communities of color are and where these negative environments are, you start to realize, like, even if there's an individual contribution to this health disparity, that the environmental factors, the socio and economic environmental factors that are impacting these communities is far beyond whether or not somebody can walk. It's actually whether or not somebody literally has a space in their neighborhood to walk. So there are these fundamental aspects of our work. That's the upstream approaches to health, right? Is looking at the ways in which those health disparities are caused. And that's where the policy and systemic change and why it's really important for CPEHN's work. So, little interaction. What does health look like? What is health to you? And that's a question you guys can raise your hand or yell out. So I'll pick on some folks. Mighty Soul. Mm-hmm. Well. So overall wellness. I saw a hand back here. What is health? Just yell it out. Just yell it out. Yes.
It's the ability to exist and move forward to meet your potential without being hindered by disease or by injury or by mental wellness issues. So not being hindered by problems with your body.
Yeah. In the back? I know you were just moving your hair, but can you just throw out a factor there? What does health look like to you? Being happy and healthy, not having to compromise. Did you have your hand up?
Yeah, I want to also add on to the rest of my classmates' comments. I also want to add that aspect of health could mean productivity. Because, for example, a healthy community rather than just a person is productive and they contribute and they're able to take care of not only themselves but others.
Right, productivity. Did anybody else over here? Did you have one? No? Okay, yeah. Great. Those are all great answers. And the way that I kind of illustrated it here was, of course, it's going to the doctor, right? Having access to health care. But it's also having a safe place to park, right? Or a safe park to play in. Having a house. Health is having a home to go home to. So you're protected from the elements. This is my son. And so whenever I have a chance to throw him in there, I definitely do. So it's early childhood education, having a safe place for kids. It's being community, right? Having that social interaction with people. This classroom right here, this is health. Fresh air. Active transportation. We should have a skateboard up there too. Productivity, money, having a job, having a regular job. Water. Having a safe, clean water to drink is health, and being able to graduate, having access to food. So we tend to think about health as being the mental, our mental well-being, our overall well-being, but sort of what contributes to all of those things is a lot of those safety factors, a lot of those sort of everyday things that we may take for granted, but that for many communities are struggling with on a day-to-day basis. So this really is quiz time, but it's going to be a fun quiz. So this is another interactive piece. How much do we spend on healthcare as a nation compared to other countries? So is it 3/4, about the same as other countries? Is it 1.5 times as much, 2.5 times as much, or 4 times as much? How much do we spend on healthcare? And maybe you guys know this from your classes. Okay, D, a couple other answers, just throw them out there. How many would say A? I'm trying different ways to get people. How many would say B? Go ahead, raise your hand, it's fine. Okay, how many would say C? Okay, getting closer. D, yeah, okay, and then E. All right, good. So it is D. It is 2.5 times as much. So we spend, on average, about $8,700 per person compared to the other economic, countries that spend around $3,400, $3,500. So because we're spending so much on healthcare, we should be living really long lives, right? Living great, healthy, long lives. So where do you think that we are in terms of other industrialized countries? Are we number one? Just raise your hand. We have the best life expectancy ever. No. Are we B in the top 5? C, the top 10. Okay, D, 20th place, more, and then E, 26th place. Okay, little split on that one. We are E, we are 26, so we're way kind of down the line in terms of life expectancy. Our average is about 79 years compared to 81 years. But this graph is really interesting because this shows you, here's where most of the other countries are in terms of their spending and their life expectancy, higher than the United States in terms of health expectancy. But in terms of spending, right, this is spending much more. This is spending about average. Look where we are as the United States. We're kind of way out there, right? So just, some things to think about in terms of our healthcare space. So this goes back to the why aren't we living longer? What are those factors that are contributing to negative health? And this is a little bit of my own framework, but there's other research to back some of these things up too, but part of it is because we have a very fragmented healthcare system, right? Where we get our healthcare, how public health is integrated into all of this, how we continue to sort of operate in terms of silos, in terms of thinking about transportation over here and land use over there and health. California's made some efforts to bring those things together. For example, health in all policies is something where we're trying to look at our policies through a health lens so that, again, our policies are not furthering those health disparities, but that they really have heart disease, asthma, all of those conditions sort of right in the forefront. But we also still continue to lack culturally and linguistically appropriate healthcare services. And I am going to talk a little bit about how we've tried in California to move those things forward. But there's also this larger issue around the socio and economic factors that really impact people's health. And so, again, this is where the health in all policies approach, the looking at things, using your health lens wherever you go in your fields so that you're informing those fields about how this could potentially impact people's health is really, really important. And a growing interest in a growing interest in California, and I think the nation as well. So I'll kind of breeze through some of these, but in terms of our fragmented healthcare system, we did a great job passing the Affordable Care Act. We've been able to insure more people. I have a slide a little bit later. But this is how people get healthcare coverage. Some of them get it through their employer. Some of them get it through Medi-Cal, Medicare. Some of them get it through both Medi-Cal and Medicare. Other people get it through the private insurance market. So we get healthcare in sort of all these different ways. And predominantly, communities of color are the most uninsured. And so this goes back again to CPEHN's founding, where we've had some efforts along the way to try to make insurance more affordable and better. And those efforts sort of failed until 2010. But it really, again, it's sort of looking at, as opposed to an individual or a group, that kind of how our system was set up, right? Going back to the other system, that you had to have opportunities. You could only have ways to get into these different systems. And it really locked a lot of people out. In the Medi-Cal program, we have also a higher proportion of individuals who are enrolled from communities of color. And so that role, Medi-Cal plays a really important role in our healthcare. And Cover California has recently played a really important role. And again, you'll see the race and ethnicity numbers, which I've circled here. The majority of those who are enrolled in those programs are also communities of color. And language has been a really important issue, and this kind of goes back to why cultural and linguistic appropriate care is really important, because over a third of individuals enrolled in Medi-Cal speak a language other than English. So these are also, again, I go back to the founding of CPEHN, where these were all the things that our leaders at the time, our founders of CPEHN, had in mind in terms of thinking about what is this going to matter for our healthcare system going forward. 20 years ago, they were saying, there is a change in the demographics. We need to be prepared and ready for that, and so these demographics all show why. And just in terms of why we don't have this, I think, again, we look at sort of the workforce issues. There's not a lot of physicians who have kind of kept pace with those who they're serving. So jump into quiz time one more time just to make sure everyone's still awake and alive back there. So this kind of goes to some of those other factors around health. So what is the single most accurate predictor of your health? So A, whether or not you smoke. It's a pretty good impact, right? What you eat, is that a big predictor of your health? Yeah. Whether or not you're wealthy. Yeah. And then whether or not you have health insurance. And then whether or not you exercise. So we got some good ones. Your income is actually the best predictor. And that kind of goes along with, I'm sure you've seen like the California endowment slides, your zip code defines your life expectancy. But your income is really important. Can I just get a sense of why do you think your income is important? Why do you think that's a measure of health?
It ends up defining almost everything about your life, what foods you eat, where you live, and where you live. What air pollution is around you, if there are parks around you, what education you get, whether or not you have to work nights while you're in school, and it goes down to almost all aspects of your life.
Yeah. In the back? Yeah.
Also, I think probably the causation runs the other way as well. If you're not healthy, then your career choices will be limited as well.
Right, so it's kind of a circular effect as well.
I would just add the stress of being lower income would also take on a toll on you.
So your income kind of defines where you live, work, and are active, what opportunities are available for you, whether or not an employer provides health insurance. Yeah.
I think it's also hard though because just if I'm like playing devil's advocate, like thinking like, oh yeah, it can affect your health, but at the same time you can be the wealthiest person and still be like have diabetes issues, like obesity, like have a lot of health issues. Like I feel like if you don't know how to take care of yourself to begin with, having all the money and the resources won't benefit you.
So there's choice as a part of all of this. But I think the reason why your income is really, really important is because when you have money, you can actually afford to pay for specialists, right? You can afford to pay for your healthcare coverage. When you're a child living in poverty and your parents work a lot and you don't have the access to the healthy foods, and the school that you go to may not have an after-school program, all of those factors are very interrelated and really sort of set that foundation for whether or not you're going to have those opportunities going forward. So these are all really critical factors. And this is just one to kind of show you like where people are in terms of the income range, right? So we have Latinos and African Americans, Alaskan Natives who tend to have in the 40s, and then you look at whites, for example, that are a little bit higher, and then in terms of some of the poverty rates as well, right? So these are some of the kind of, again, more systemic challenges that we face with in terms of looking at health disparities. And the types of health disparities, you can sort of see the correlation oftentimes with income and where folks are in terms of some of the conditions that they may have. Language is also a really important factor in terms of disparities as well. Have you guys seen this one, right? So equity is not equality, right? Just making things equal for people, giving everybody the same thing doesn't always work for people who have over and over again kind of face different challenges or barriers, whether it be a language or an income barrier, education barrier. And so oftentimes when we look at equity, we may need to give some communities a little bit more in order to raise them up higher to be able to reach that apple or to be able to reach that opportunity. And these are some of the concepts. Not perfect by any means, but essentially health equity is really what we see it as health equity is the attainment of the highest level of health for all people, and means that all people have full and equal access to opportunities that enable them to lead healthy lives. Health inequities are differences in health that are avoidable, unfair, and unjust. So when you have those systems or those environments in place that could be avoided, had we made some decisions, had we made some other decisions, they could have been avoided, and that would have meant that these communities would not have been as unhealthy. And then health disparities is those other pictures, right? Those are the conditions that have a higher proportion in certain communities. And so I'm going to talk a little bit about how we can focus on health equity, but just at a basic level of understanding that as we're working with community folks, as we're working with policymakers and through the data, is to really show that equity really requires valuing everyone equally so that you have these focused, ongoing efforts to make sure that we can avoid inequities and we can avoid inequalities and really help to eliminate those health disparities. So it's just keeping that perspective in mind about how can I think about a policy or think about an environment that would help somebody who may not have all the opportunities, lifting them up, and I think that actually lifts everyone up as well. So in our work, I'm going to talk about the policy, but I also wanted to show some pictures of the community engagement efforts that we do. So we work with a lot of different community-based organizations around the state, and we do really fun things like bringing folks to Sacramento to testify. And people have some really amazing stories, and I think what we've learned in this process is that our community members really are the experts about what they need. They may not be able to talk about it in legislative terms or through, in the form of a bill necessarily, but in a very basic way can help us understand what they need in order to be healthy. And oftentimes that translates to, I need to make sure that we have sidewalks in our, in our area, that we have a park that we can play in. I need to be able to communicate with my doctor. I need to be able to share some of the things that in my culture, are honored. Those basic types of understandings, those are the experts that we know, and we try to create opportunities for our experts to share those experiences with policymakers, because as I'll talk about, being a constituent and having a story really does matter and makes things very real for policymakers. So I'm gonna, in the last couple of minutes that I have here, I'm gonna talk about legislative and administrative advocacy. And very briefly, the two are very different processes. So how many have you ever looked at a bill before? You know what a bill is? Yeah, okay. So the legislative process, the great thing about it, you're making a law. You're basically making a law. So you're taking something, you're maybe identifying a problem, and you're turning it into something that people have to abide by. Not just people, but also state agencies or the government, and they're gonna enforce this. So you're often working with the legislature, for example. There are multiple opportunities for input in the legislative process. They have hearings, bills go to things called committees, and they have hearings on those bills. There's information, there's requirements about having to post that information online so that people can go see it. Committee hearings are published. It's a very public process, in other words. It's very easy to engage in legislation. And then you can have both a local strategy as well as a statewide strategy. Administrative advocacy is a little bit different. Who here has ever worked for, interned with, or knows what state or local agencies do? So nobody's worked for a county before? Have you ever contacted a county for anything before? Like a public program or? No, yeah, kind of. So state agencies, local agencies, they essentially, they oftentimes administer programs. So for example, the Medi-Cal program is our public program that provides health insurance at the county level. And that is something that would go through a county health department. Your public county health department, they do things like education. They provide information about why vaccines are important, right? They do a lot of community education and engagement. At the local level, you would talk about transportation, for example. So they might administer the transportation funding that's going to create new roads, build bike lanes, and look at different ways, right, to have a more active community. Their process is not always as easily accessible. When you're working with a state agency, you're usually interpreting a law. So a bill that you may have passed, you're now going to work with a state or a local agency to talk about, here's the intention behind the law, and here's how we want to see this law being implemented. And it's oftentimes a more closed process. Sometimes when there's a regulation, there'll be a notice that's put out to the public that says, hey, if you're interested in this, you can come and engage in the process. That's not always the case. And so oftentimes you have to have a relationship with a county or state agency in order to weigh in. But the good thing about it is that there's always ongoing opportunities for relationship building with state and local agencies. So, and I think this is true for both administrative and legislative work, but I'm going to kind of frame this from a legislative process. So as we were looking for, bills that we may push forward, oftentimes bills come about because there's a problem. Something isn't working right. So for example, in private healthcare companies, we noticed that there was no requirement for a health plan to provide an interpreter when somebody was going to the doctor. And we felt like that's going to be a problem because there's no requirement. Some plans were doing it, but it wasn't across the board a requirement. So you identify a problem and then maybe some potential recommendations. You want to go through, you got to research that policy, you got to look and see if there's anybody, the history is very important, right? Seeing if there's anybody who has introduced a bill on that or looked at this issue before. And then there's a couple of other steps that you would want to do if you're working a bill, like identify an author and work with legislative staff, gather supporters, make sure that you yourself write a letter of support or go testify on your bill, and then also develop alternative strategies, because sometimes your bill doesn't go through the way that you introduced it. So this is an example, as I was building on. There were 3.4 million privately insured individuals who did not speak English. And again, there were no requirements in the private health plans to provide health insurance interpreters. Public programs like Medi-Cal had some requirements, but in Aetna, for example, through your employer, did not. And so there was a newly formed state agency, and we started to meet with them, and we said, hey, we would like you guys to issue a rule or to talk about, set some standards around this. And they actually said, no, we can't do that. We don't have the authority. If you want us to have the authority, you have to do a bill and you have to give us the authority. And so we ended up working with the department to create a bill that did actually give them the opportunity to set those standards. Through those standards, they then went through a regulatory process. So we outlined some of the basic parameters that they would have to develop and use for their requirements. And then as we moved through the process, we went a lot more in detail and through their regulatory process. So as advocates, we weren't alone in this either, because who might else be impacted by this kind of a policy? We're looking from the consumer perspective, right? But who are we kind of targeting, if you will? We were targeting providers and health plans. And so they want to have a voice in this process too, right? It's not just us. We don't get to, it's not one-sided. So we went through a series of negotiations, and we actually did a series of hearings around the state, having folks come and talk about their challenges and what it would mean to have an interpreter. But we also were confronted by health plans, for example, who would talk about why this would be a burden to them. What would be the impact on their business, for example. We had some health plans and community clinics who would also talk about the benefit, right? Having interpreters, having language assistants also helps us because it creates more business for us. So that's part of the administrative process is you're weighing the different factors, you're weighing in, and you're talking about what the impact is going to be. So this is just a little bit of a recap, but basically the opportunities were the data was showing us that this was a policy that needed to be in place. We had a champion, we had a political champion who was willing to move this issue forward for us. And we had really strong coalitions around the state who helped us move this issue forward. This was not an easy lift. Creating a mandate or creating a requirement for a health plan is really important. And you would think about it the same way as if you're creating a requirement for developers in your local county, right? If you want to do more affordable housing, here's the way that we want you to do it. And they're going to have a decision. They're going to have a say on that particular issue. So it's a pretty huge lift when you're asking for this kind of thing. But using that health equity perspective, right? Having consumers be a voice in the process, having consumers talk about why this was important for their health care and what it was going to mean for their health are really, really critical things. And so that's the health equity perspective. This is just a quick summary. We have a report on it as well. And then there's various different tools that we use along the way. And this is where it gets kind of fun because you want to be creative about how you're crafting your message. So you can always write a letter of support and talk about, you have all the data and the information, all that research that you do, you're now folding it into that letter of support. But you also get to call and meet with your local electeds or your state elected officials and talk about why this is important. And this is, again, is why making it real and having your community experts be at the table to talk about why this is important. Testifying, so how many of you have ever testified in a hearing before? Very few. It's a great learning opportunity to kind of track an issue and talk about why it's, I mean, even today I still get nervous when I do testimony, but when you're really passionate about your issue or you have a lot of data or information, it's amazing to see people blossom, or it's amazing to see what change can happen. We do a lot of rallies, we do a lot of lobby days, sort of bringing these big coalitions of people together in Sacramento, again, to show policymakers in Sacramento, for example, who are often sort of distanced from their communities, why this is an important factor. We do a lot of fact sheets and also action alerts just to get people sort of activated and moving forward. So the other issue I want to really quickly talk about is, we also took a lesson learned from, there was a transition that was happening for children's coverage. So children were moving from one healthcare coverage into another. And we were going to lose some potential data. And so we used this as an opportunity to kind of rally folks and create new contract language with the department so that we didn't lose that data. So again, kind of having that internal perspective about what's happening is really, really important. So the last thing I want to quickly mention is just on the Affordable Care Act. So we've done some really great work in terms of expanding coverage. We talked about that fragmented healthcare system. Before the Affordable Care Act, single childless adults, unless you could buy into the insurance market, it was very difficult for folks to be able to get coverage, particularly if you were really low income. Very little regulation. If you had a pre-existing condition, hard to get in there. We had about 11 million people who did not have access to healthcare coverage. What the Affordable Care Act did was it expanded Medi-Cal so that low-income adults could be able to get insurance, which was, again, a huge step. It was changing the systems to then being more proactive and allowing people to come in, as opposed to keeping those systems closed and limited to just a few people. In addition, we provided tax subsidies to help people financially be able to afford healthcare coverage because it's not cheap. And so that helped working people be able to buy into the insurance market as well. So we have about a little over 1 million people enrolled in Covered California. It created this welcome effect. So people who were not enrolled before became enrolled because there is an individual mandate, but it also helped to just raise awareness about what programs and services were available. And so now as a result, we've dropped the uninsurance rate by half in California. So now over 5 million Californians are enrolled in healthcare coverage. 97% of kids are enrolled in healthcare coverage, which is great. We've really shrunk that uninsured rate for children. And as a result, many, many people from communities of color have been able to access healthcare coverage, which, going back to looking or thinking about those health disparities and having the ability to be able to manage those conditions is really, really important. So we still have a lot of work to do. We have a lot of work in terms of just, improving the quality and affordability of healthcare coverage. And we also have a lot of work in terms of looking at those other systemic challenges that really help to improve and link to the health access of individuals, looking at poverty rates, right? Looking at making sure that communities are healthier, making sure that our healthcare systems are also welcoming and able to care for our very diverse communities. So I'm going to stop there, but I'll just kind of pose these questions to you as you think about questions for your own. But I'd love to think about, or love you to think about, how would you take this information back to your communities? What might you do with it? How might you engage in policy in a way that maybe you hadn't thought about before? What are some opportunities that you could see on the horizon? And who might be some champions that you would look to in your local communities? So with that, I'll stop and I'll see if there's any questions. Yes. Oh, yeah. Yeah, so I went to law school just because I really wanted to go to law school, because I talked about at the beginning that law was a really important, it's one of the tools that you can use, right? And right now we're seeing a lot of the use of the legal tool. And so, doing public policy, I actually did a lot of the work that I did it without even a master's degree, because I think policy is one of those places too that when you know the issues and you actually know the right folks and you can follow along and sort of, you can actually engage in policy very easily. Again, a lot of our community folks that we work with, they're doing policy at the local level. They're doing it within their own communities, and they don't necessarily have time to have the master's degree. But what's helpful is, for us in particular, I am an attorney, so I don't do math. It is nice to have an MPH student or somebody who can help us run the numbers and do some of that analysis. So, having the MPH degree is really great for that. And you don't have to think about having a law degree necessarily to work on legislation. It helps craft language or do some different things, but it's not essential to being engaged in policy by any means. And actually having that master's degree, public health degree, is really important, a way to help think about and analyze the different data. Yeah. Yeah.
So now that we have a new presidency underway, there are massive implications for both our healthcare system and communities of color. So knowing that there might potentially be 4 or even 8 years of Trump upcoming, what do you feel is the greatest challenge facing your network, and how do you seek to address it?
Yeah, so we are really actively engaged right now, and part of the reason why I put up the slide around the Affordable Care Act is because I do think it's important to understand, what are the implications if there are erosions of the great strides that we've made in terms of offering healthcare coverage, for example. So I'll take the healthcare coverage, and then I'll look at the other part of the question. I think California, and what we've been emphasizing both at the state and federal level, is California is really the poster child for the Affordable Care Act. We've done everything pretty much right. We have a really strong active purchaser, which has covered California. So we have a number of different healthcare insurance companies who are really active in that system, that are utilizing that system to be able to bolster and expand their enrollment in their healthcare plans. We've worked really hard to make sure that the contracts that the state has with them include efforts like reducing health disparities, that they're providing dental coverage, that we're really trying to maximize their participation in this healthcare system. We also expanded Medicaid. Many other states did not expand Medicaid, and I think part of what you're seeing at the national level in terms of some of the pushback is people who could be eligible for healthcare coverage are not getting it because their state made a certain decision. And so I think, again, in California, we have seen that, which is why I think we've seen such a dramatic impact in terms of reducing our uninsured rate. So that's one of the things that's really at stake right now. And so there's both a state coalition and a national coalition that is trying to help preserve and defend the Affordable Care Act. But I think more broadly, we are seeing this huge shift. And I bring up where California was 20 years ago because I think that's kind of where our nation is. Our nation is changing demographically, and I think for some communities that's a frightening perspective. And I think what I'm trying to show here is that by embracing that perspective and actually by leading with that perspective, we can have much better policies that are very inclusive for folks and that create better health, rather than taking the perspective that we need to limit and create or limit people from being able to access different services, or that we can't extend a hand to different people. That instead, having California has moved into a very inclusive place, and I think that's where we're trying to advocate. And so CPEHN is one of those voices that's saying, by advocating and having a more inclusive policy, we're actually helping to improve people's health. Thank you. Yeah. Any other questions or thoughts?
I have a question about hidden populations. You know, so for example, Orange County didn't come up as being a community that is predominantly of color. And I wonder, because in the white category, a lot of Middle Easterners get lost in those categories of other and white. And I know that there's been a rise in Middle Eastern populations. And somehow I think these hidden populations, we need to take another look at it. I know that the last census, there was a huge push for Iranian Americans to actually put other and put Iranian American just so that we have more accurate numbers of where our communities are at. I'm just wondering if we're dealing with any of those, understanding or unpacking that data a little bit from.
Yes, so 3 quick points as I wrap up. One is that there are a lot of intersections with demographics, right? So a person of color may also be limited English proficient, may also be transgender, may also be an immigrant, right? So just because you check one box doesn't mean that you're not impacted by multiple different, identities or multiple different things. And so I think the other perspective that we're trying to bring to the table is that we need to be thinking about policies from that more intersectional place where you're looking at how people are impacted in different ways. And we've been doing that for a long time around race, immigration, and language, but I think now really trying to fold in the aspect of gender identity, age, et cetera, disability, for example. There is a move to try to do more what's called disaggregation of data. So rather than rolling up into one particular category like Asian American or Caucasian or white American, is to actually start to open that up a little bit and have a better sense of who falls within those categories. And so we had a pretty contentious bill last year that would look at disaggregating the Asian Pacific Islander American community. And I think there's some, communities who really don't want to do that because it could separate different folks. But there is a growing number of Pacific Islanders and Southeast Asian communities that are very interested in that data because they want to know how cervical cancer, how smoking rates, how other different issues are impacting. What are the health disparities within those smaller communities? And the way our data is set up right now, it's a little bit difficult. Data in itself is a really challenging subject because we want to get the most data, but we also know that we have a challenge sometimes with sample sizes, or so we're definitely working on how to mitigate some of those efforts. But I think having a broader sense of who's there is really important. So the last piece that I'll kind of close on, which touches just upon our current situation right now, is that the census is a really important way for us to be able to get data. And I think if we want to look at, or if we look at some of the changes that are happening at a federal level, the Census 2020 will be coming up in a couple of years, and that's going to be a huge impact. And so a lot of the foundation that we're setting right now around sort of scapegoating immigrants or making certain populations feel either invisible or not included will have implications for the Census Bureau as well. And that has implications for the long-term planning of this state, but also our country. And so it's, again, really important to kind of try to rise up above that, and to the extent that we can as a state, talk about the inclusive way that we've chosen to run our state and work our state, and how that can have really positive implications for the nation. There are some very looming challenges that we have as a nation, and so I think we just have to be persistent and use the tools that we have to really keep promoting health equity.
Thank you.
Thank you.